Check 1 2. See if you hear that in the stream. It's gonna be a little. It's gonna be a little delayed, like just the stream delay. You got it. Perfect. Okay. All right. We're all set. We're all ready to go.
Yep. All right, everyone. Good to see you. It's been such a long time. This is the added value of Eastern Pulmonary Conference. We're always pleased to have this CME by Academic CME. Fantastic group. You will get CME credit. Very important. I'll be showing you QR codes. Please scan the code. The one code you could, there's a pre-test question. The final QR code is going to be for your CME credits. So please avail yourselves of that. Make sure your cell phones are charged so that we can rock and roll here. I know that we have tight flights at the end, so I know that our speakers are aware of that, and we'll keep it very succinct. It'll be new and novel things that you're going to hear about. It is a real pleasure to introduce one of my colleagues from Philadelphia, who's going to be talking about the clinical update on non-cystic fibrosis bronchiectasis, strategies to manage exacerbations and improve lung function. He has a long, distinguished career in this space, and with no further ado, we introduce him just briefly. Here is the agenda. It'll be three talks. These are the faculty disclosures. And this is the pre-test QR. All right, please take the opportunity to scan this. And please take the time to answer the questions in the pre-test. That'll lock you in for our Fund of Knowledge and how we can improve this program from the Fund of Knowledge standpoint. Questions to the faculty can be done through this. I have an iPad that I could certainly utilize the questions, but let me suggest after 2.5, 3 days, I think we're all friends in this room. It's an intimate group. Just come to the microphone. We just don't have enough millennials in the room to justify the use of the QR code. So I'd much rather hear you, see your lovely face, ask the question, because we're all amongst friends here. So with that, off to the races.
All right, thank you guys for being the Iron Men and women of this conference and making it to the last day. I'm going to talk about an update of bronchiectasis, really with a couple of cases to try to highlight some information here. From a learning objective standpoint, a little bit about the therapeutics and strategies that are most appropriate to try to improve outcomes of these patients. So in terms of bronchiectasis, I'm going to blow through a few of these slides pretty quickly. If you went to Patrick Flume's talk, it was fantastic and highlights some of these things. So there is a little bit of overlap, but just want to hammer home, bronchiectasis has been described for over 200 years. It's been there, but really not recognized quite as much as it should be. In any patient with chronic cough, sputum production, recurrent exacerbations, you should be thinking about it. And then the diagnosis really comes from that image to see that the bronchial tubes are more dilated than their associated vessels. So when we talk about treatment for bronchiectasis, really it's get the stuff out of the airways, try to improve mucociliary clearance, get the phlegm out. We want to reduce inflammation and then prevent recurrent infections. And with this, the hope is that we can mitigate some of the ongoing or structural lung damage that happens from this, decrease airflow problems, improve people's quality of life as well as exercise capacity, and then try to decrease exacerbations. In terms of recommendations, we really draw on places outside the U.S. for the current guidelines. The most recent ones are from the British Thoracic Society. We're hoping to get some new iterations coming in the next few years, and there are working groups that are looking at this now. But really, at this point, unfortunately, pretty much all treatments until August 12th have been things that we've stolen from cystic fibrosis or taken from other disease processes. And then actually, earlier last month, we had a new medication, brensocatib, that was actually approved specifically for bronchiectasis. So when we're talking about treatment, I think a couple of things I'd really like to highlight. The first thing I think is probably the most important, and this is really educating patients about what the disease process is and expectations, really level setting that this is something that doesn't go away. It's something that you try to manage and is going to be lifelong. And so the more patients can kind of understand that, the more we can express it to them in ways that they can understand, it really allows for the treatment to become a little bit easier to understand why we're doing what we're doing. I like to break treatments into sort of cause-specific therapies and then cause-agnostic therapies. Obviously, if they have things that we know that cause the bronchiectasis, those should all be treated appropriately. And then those cause-agnostic therapies, it doesn't really matter how they got to the bronchiectasis, but things that we should be focusing on, such as airway clearance, trying to treat infection, particularly chronic colonizations or recurrent exacerbations, anti-inflammatory therapies, most recently the neutrophilic inflammation therapy that was just approved. And then we want to set some sort of frequency for regular follow-up, check-in, see how patients are doing, and then intermittently through that time, again, treat exacerbations. So I'm going to talk about a patient, and actually kind of interesting timing. This patient I saw in clinic actually the week before this conference. I was looking through some old patients to try to see in the morning on Tuesday, and I'm like, all right, I got to go to clinic, and lo and behold, this lady walks in as a new patient to see. She's 68 years old. And the reason that she's coming to me in clinic was for bronchiectasis. She was a logistics officer as a career in the Army, so she figured out how to move people and things from place to place and had a long career. And she really was a very fit woman for most of her life. She did annual PT testing. She could run 2 miles in under 14 minutes, even at the age of 59, which is pretty impressive. But when she retired from the Army, she started to notice without regular exercise, her health started to decline. She was a social smoker early in her life, but quit. And at some point in her 30s, related to probably a workplace exposure, she actually started to have symptoms that were diagnosed with as asthma. And so she kind of came to medical attention again after an episode of hemoptysis, and this is when sometimes these cases are found. And she got hospitalized in January. Unfortunately, her husband was also very ill, and so she left the hospital against medical advice and really was lost to care for about 9 months until her husband passed away. And then she came back to try to get her care taken care of a little bit better. Over the course of the last year, she had had 3 hospitalizations for pneumonia and was treated with antibiotics. And a couple of interesting things from her past history is she had a bronchoscopy procedure performed when she was about age 35. And on that bronchoscopy, somebody told her she had Pseudomonas. She couldn't really remember why all this happened, but that was a red flag for me of, hey, something's been going on for a long time here. And then no real family history of chronic problems. Not going to read through everything here, but on exam, one thing I want to highlight, she's a really thin woman now with kind of decreased muscle mass. Her BMI is 16, and then she just had a junking-sounding lung exam. She had had a lot of testing kind of piecemealed as she came to see us in the clinic and had, kind of the normal workup that you would think of for bronchiectasis with looking for immune deficiencies, cystic fibrosis, other genetic potential causes. One thing that jumped out on the workup was that her eosinophil count was pretty high. And then she had had cultures multiple times over the last year with these pneumonias and had grown 2 different strains of Pseudomonas. She had had multiple other cultures looking for atypical mycobacterium, and nothing ever grew from any of those. And fungal cultures had been negative from both bronchoscopies and expectorated sputum. Lung function was a little bit on the lower side, and she had been on supplemental oxygen, but they hadn't really done an evaluation for how much oxygen she needs and when she needs it. So she was only really using it for exertion, hadn't had a 6-minute walk test or overnight oximetry testing. And this is an example, or just her CT scan from her recent hospitalization. And if you can sort of look at the different levels, it looks like the bronchiectasis involves pretty much all of her lungs. On the bottom right-hand side, you can see that her left lower lobe is very consolidated, as is the lower part of her right middle lobe. And kind of diffuse disease with bronchiolitis, airway wall thickening, mucus plugs, things of that nature. So this is really kind of where I want to focus a little bit of time on, is the treatments. So when she came to me, she was on 2 nebulized therapies, a long-acting beta agonist and an inhaled steroid. She was using albuterol a few times a day, and then she was using a vest for about 30 minutes once a day. She had been prescribed, after the first culture of Pseudomonas this past year, nebulized tobramycin, which she was using cycling every other month. And then she was on oxygen, prescribed 24/7, but she was really only using it with exertion. So whenever I get a patient like this that comes to clinic, my first thoughts are, what are we doing that's hurting somebody, and what are we doing that might be, what are we not doing that they may benefit from? And so I kind of go through this list almost in every patient that I see. And the first thing I always start with is airway clearance. What's she not doing, or what is she doing? She's using the vest once a day for 30 minutes. Is that enough? She's not on hypertonic saline or other mucolytic therapies that might be of benefit. From an anti-infective standpoint, she does have multi-drug resistant Pseudomonas. And is the Toby really adding any benefit here? Unfortunately, it hasn't really kept her from exacerbating. She still had 3 hospitalizations. Is that the right therapy to continue? From an anti-inflammatory standpoint, azithromycin had never been tried in her, and she had also had multiple negative AFB cultures, so that might be an opportunity. Brensocatib obviously is something that has just been approved, and this may be a good option in this patient. The oxygen, I think, is something that's important too. This kind of gets back to the talk we heard about pulmonary rehab. I think pulmonary rehab in any chronic lung disease is helpful. So getting and keeping people moving, exercising, keeping respiratory muscle strength up is very helpful. And then nutritional support. So this is, again, BMI was really low. She had some evidence of cachexia with muscle loss, and that would be of good benefit. And then talking about sort of the transplant idea. She has pretty significant lung disease, and that was really her only major problem. She had a little hypertension, but it really is a respiratory illness, so transplant may be an option for her. And then the last thing I'll bring up are biologic therapies. There are multiple biologics. These aren't the only 2 that would be potentially available, but there are some clinical trials looking at these right now. Dupilumab may be another option, or other types of biologics to try to decrease the asthma or allergic component of her disease. So airway clearance, just kind of highlighting what Dr. Flume talked about the other day. It's really trying to find out what's the best option for the patient. She was kind of given a vest and never used an acapella, no handheld devices, no positional drainage, any other ways to do airway clearance. So I think it's very important when you see these patients to find out what they've done and try to expose them to other options. So she actually had some time with our respiratory therapist to talk about different versions of airway clearance and what may be helpful. Being tied to an electrical outlet, or even a vest that's battery powered is tough because it's really done in the home, and if you're traveling, you might need something that's more portable. In terms of the underlying cause, again, want to harp on this a little bit. Unfortunately, in her case, she had the workup essentially for all of these, and nothing really came back positive, so we didn't have a specific etiology, but want to keep in mind, did everything get looked for? And then, the macrolides, I think in her case, again, there is some suggestion of decreasing exacerbation frequency, maybe some improvement in quality of life. That actually could be a good option in her. She had been tested for atypical mycobacterium multiple times, and it was negative each time, so this may be an opportunity that may help her as well. And then I want to highlight a little bit about exacerbations, and this kind of gets into, talking with the hospitalists and people that bring pulmonologists in on consultation. Everything's pneumonia or it's a COPD exacerbation, I feel like, in our hospital, and those are the only 2 diagnoses people know about. And a bronchiectasis exacerbation, it's got a different connotation. The therapies are going to be slightly different, so we want to make sure we're calling an exacerbation an exacerbation. So in terms of the definition, the BTS came up with, a definition that was more clinically relevant and has kind of been around since, the last 10 to 15 years, but really a change in respiratory symptoms that needs a treatment. And that really is pretty broad, obviously. Just this past year, they came up with a research definition, and this is really so that we can standardize clinical trials, but I think it sort of highlights the same things of cough, change in mucus production or type of mucus, respiratory symptoms, some fatigue, things like that, and some doctor or clinician decides that this needs to be treated. So it doesn't really specify how it needs to be treated, but the change is such that an intervention needs to happen. And why do we care about exacerbations? This study was done by Chalmers and was published several years ago, but really important information to say that there's a decrease in quality of life the more frequently you have exacerbations. There's an increase in hospitalizations, obviously, the more you exacerbate, and there's a survival decrease for more times you exacerbate. So exacerbations are very important in these patients, and they need to be taken seriously. So I'm going to switch gears for just a second, go away from her case. Unfortunately, I don't have an outcome yet because I just saw her this past week, but I think it highlighted some areas that really more thought-provoking of where you would want to go with a patient like this. And then with the recent approval of a medication, kind of highlighting again some of the stuff that Dr. Flume talked about with neutrophil inflammation in the airways in these patients with bronchiectasis. And when there's a lot of neutrophilic inflammation, things kind of go haywire. It seems like it's too much of a good thing, as he mentioned. We kind of want the Goldilocks idea, but the idea of targets that might be able to bring down the intensity of neutrophil activation in the airways was really kind of what led to the idea of this new medication getting approved recently. And there's 2 studies that, again, Dr. Flume went through pretty quickly, or pretty recently, so I'm just going to highlight a few points of. And these trials really were designed to look at people that were frequent exacerbators. So that obviously is the group of patients that are the sickest. These are people that had at least 2 exacerbations per year, and they were looking at trying to decrease exacerbation frequency, hopefully looking for some signals in quality of life, sputum production, those sorts of things. And in the phase 2 trial, they were able to show a decrease at either dose of brensocatib in terms of the exacerbation frequency. They were also able to show that there was less neutrophil elastase in the sputum of the patients that were treated with the medication. So it's working by the mechanism with which it's supposed to be working. And then the phase 3 trial, which was completed about a year ago, it included very similar patients. I think the nice part about the trial is all of the groups were very well matched. So they didn't have any unfortunate randomization problems that might account for differences. It seemed like the groups were very consistent in terms of age, race, BMI, the causes of bronchiectasis, their lung function, number of hospitalizations, that sort of thing. And again, the goal of this study was looking at exacerbation frequency. And all of the patients had had multiple exacerbations, with the exception of the younger cohort, which had had at least 1 exacerbation. And kind of a busy slide, but ultimately, the finding was very similar to what we saw in the phase 2 trial, where there was a decrease in frequency of exacerbation, time to first exacerbation. And then interestingly, and this is sort of a subgroup look, is in those patients that received the higher dose of the medication, of the brensocatib, the 25 milligram dose, there might have been less of a rate of decline in lung function. And I think this is where I have a ton of questions about what to look at in the future, because this, again, as I think Dr. Flume highlighted, it may suggest some disease modification, which is something that we really don't have much of in bronchiectasis. From a safety standpoint also, very similar across groups. There didn't seem to be big problems. I think the biggest concern, most pulmonologists or most people that are thinking about this medicine are, if I'm going to bring my neutrophil activity down, am I going to see more infections? And that's one thing that was not seen. It did not look like there were more exacerbations, quite the opposite. They didn't see much in the way of pneumonia, so that's a good finding as well. And that brings me to my second case, and this is more of a provocative kind of question to kind of see how the group would feel about this. But this is a lady that we've been following in our clinic for about the last 5 years. Her her primary doc had referred her to us after she was found to have CT with diffuse bronchiectasis. And she had been on basically triple therapy for, asthma, COPD kind of diagnoses when she came in, and really didn't have much change in her symptoms. She does have chronic cough. She brings up phlegm. She doesn't really get sick very often. This is somebody that's been on antibiotics over the last 5 years, just twice. And they were both outpatient antibiotics. She resolved pretty quickly. She's had a bunch of cultures over the years as well, and really no specific pathogens have been found. She always grows heavy growth of normal respiratory flora, which if you're like me, you get frustrated by that answer. You know there's something going on, but you can't find exactly what it is. She uses airway clearance also, so she's somebody that does the vest and hypertonic saline. And this is her CT scan, which isn't quite as bad as the last one that I showed, but she does have a lot of bronchiolitis, a lot of nodular disease, a lot of dilated airways, and some mucus impaction. And then I think this is kind of the more important slide, really looking at the table. And this patient is somebody that over the last 5 years has had a very steady decline in her FEV1 and has gone from basically when she started seeing us of an FEV1 of about 85% down to 65% over 5 years. And she's not getting sick frequently. And the evaluation for other causes of the bronchiectasis, bronchiolitis aren't really giving us much in the way of answers. So I guess I should go back real quick. I think this is one of those patients that I'm wondering about. Is this the right patient to consider an anti-inflammatory medication on? Brensocatib, maybe. It's not the group of patients that were studied in the clinical trials. And that's the hard part, again, is we're trying to intervene early on most of our bronchiectasis patients so they don't get to the point where they have 3 exacerbations per year, but maybe they don't get sick enough to need more than oral antibiotics. But would this be a good patient, maybe in that subgroup of the higher dose of the medication, to potentially try to prevent some future destruction and see if we can keep her from getting sick over time? So in conclusion, really, with the diagnosis, you want to find out, is there anything that I can treat that I know the name of, any underlying diagnoses? Airway clearance, airway clearance, airway clearance, if you're a bronchiectasis doc, is really where everything kind of starts. Exacerbations are really important to deal with because they will worsen quality of life, they will increase hospitalizations, and they will decrease survival. And then now we have a new medication that just came out on the market about 4 weeks ago, and patients are starting to get on this medicine. But due to its mechanism of action, it's going to take us a few months before we really see how they all respond. And is there an opportunity to intervene a little earlier? I was kind of happy when they got the approval of the medication that it doesn't require multiple exacerbations. We'll see how insurance companies take that and if they have more and more denials because of people not exacerbating enough. But I think this is a ripe area of future looks. And with that, any questions?
Fabulous job. I'm going to take the prerogative here to ask the first question. We have an intention to treat all these people, and we all have these people that are incredibly difficult to manage, and they're all on inhaled corticosteroids. She was on, in the first case, was on nebulized budesonide, all right? So,
Right.
That's substantial delivery of an inhaled corticosteroid that could be problematic. What did you do with her budesonide? Did you have the intestinal fortitude to stop it?
Yeah, that's a great question. So we had a long
you.
discussion about the budesonide up front, and in the discussion of trying to do no harm, we talked about, hey, maybe this medicine isn't the right one for long-term use. So actually what we decided on is cutting her dose in half and trying to see if we can start to de-escalate. How does she do? So I don't have an answer in terms of how she's going to do. The other opportunity may be, again, a biologic that maybe it would allow for less of a steroid need. But she got up to that purposely. So getting off of it, I think, is important, but with some thought.
Yeah, I think that's a very reasonable approach, tapering the dose and seeing if that's going to be a trigger or not for exacerbations. There were other questions. Yes?
Concomitant non-TB mycobacterial infection affected the efficacy of the drug, or there was no
Yeah, unfortunately, that was, people could have colonization, but they couldn't have active infection. They were excluded if they were on treatment for an active infection. So I think that's another group that's going to be really interesting to look at, are people that have chronic colonization of AFB, MAC or other subspecies, and kind of see what happens with them. Theoretically, if they're not having active infections, that need MAC-specific therapy, that's an easier one. I think the harder group, and a group that we're kind of discussing a little bit right now, are those people that maybe they've been on MAC therapy for a year, they're culture negative, they're still finishing their course, and is it early enough or not too early to maybe consider starting them on the medication because they don't have active infections? I know that some of my ID colleagues are a little nervous to pull the trigger too quickly. You do need neutrophilic effects to get rid of the bacteria, but in those patients that have really high sort of BAL neutrophil concentration, the conversation's starting. I don't think we have the answer yet. In us.
Jeff, I have a question for you. And again, it could be controversial, but if you don't mind going back to that first CAT scan for that patient, because we are so excited right now about the DPP1 inhibitor and potentially, the disease-modifying aspect. So hear me out here.
Yeah.
Would you consider, like we always teach fellows, if you have a focal bronchiectasis, you can just resect that area and you have the cure, right? Now, this lady does not have focal bronchiectasis, but clearly the left lower lobe is super messed up.
Yeah.
Would you consider that our thought about this could change as we have potentially disease-modifying agents where we can maybe consider resection for maybe severe areas of the lung where I know the Pseudomonas is hiding in that reservoir, and that could be a potentially beneficial effect?
Yeah, I think that's a phenomenal question. I know we have a lot of discussions with our thoracic surgeons about specifically that. If you have a focal area of bronchiectasis, I know that in the past we've been very scared of people that have chronic colonization of nasty bugs, that it's throughout the lungs and you're going to reseed or have a hard time healing an area that you take out. But if we can start to clear other areas and that left lower lobe could come out, that's definitely, I agree with you, that's a big part of her problem. She's got, unopposed blood flow through that area with no ventilation. That's probably a part of her hypoxia. That's an area that's just going to hold on to pus, and it's a really hard area to do airway clearance with. So I do think that surgical approaches would be things to talk about. I think convincing a surgeon is where we run into trouble, but that's where longevity helps. The more we've been following somebody, if we can kind of show, hey, we're clearing up some of the upper lobes and the other lung, do we have an opportunity to take out the area that we know is causing problems?
Yes.
While we're giving you questions that don't relate to the trial, on your mild case,
Yes.
I mean, a phenomenal drop-off in lung function. Somebody can run 2 miles in 14 minutes at age 59, and by age 65, she has a 65% FEV1, clearly really sick. But if you were to start brensocatib, how would you know whether it's working or not working? If someone's in the trial criteria, you just say, well, we know people meet the trial criteria. If you put them on it, on average, they're going to get better. But here's a lady who doesn't meet the trial criteria. So do you have a way, are you going to watch that FEV1 for a year or two? So that's question one, is how would you use it in that lady, and how would you monitor whether there's response? And then a semi-related question is, would you ever go completely off-label and give her periodic treatment during, sort of around the time of exacerbations to minimize the neutrophil elastase damage sparked during an exacerbation?
All right, so from the first question standpoint, I think that's one of the big things that we're trying to figure out is how do you watch? We tend to get spirometry at least every 6 months in every patient that comes in, and I think these people that we may be considering, not those that fit into the trial well, but those with kind of the smoldering decline, we may increase the frequency with which we get imaging or lung function testing. PFTs have been notoriously unhelpful in bronchiectasis. Interestingly, in CF, they have been somewhat helpful. But that would be one thing, is to see, is there a signal there? I think the imaging is another piece where if we can see less bronchiolitis, less mucus plugging, it's going to give us a lot of comfort that there may be some changes that may slow ultimate lung decline, but we're not going to see it right away. And then the second question, are you talking about taking breaks from brensocatib around the time of exacerbation or treating exacerbations with intermittent brensocatib? Yeah. So I think from the mechanism by which brensocatib works, it has to work in the bone marrow, and it takes 2 to 3, maybe 4 weeks before we're really going to start seeing much of a signal. I don't see it working fast enough where I can sort of predict if I can bring those neutrophils down. Maybe there could be those patients that kind of have these exacerbations and they just won't get better, that it might have a better opportunity to act, but I think it's just not fast enough for the acute exacerbations. All right, thank you.
All right, thank you so much. Wonderful, wonderful job. Our next speaker, we all know Nick Hanea, and he's professor of medicine, director of Airways Clinical Research Center at Baylor College. It's a thrill to have him. He's going to be giving 2 back-to-back lectures, so I'm not going to reintroduce him because his titles haven't changed in the next 30 minutes. Then we'll be finishing up. Remember to go to the QR code, please. Do the pre-test, and then to get the credit, it is important that we use that scanned QR code subsequently. Nick, a pleasure.
Thank you so much. Thank you for inviting me. I would like to thank the academic CME for inviting me to give a couple of talks on COPD. And it's a pleasure to be here with every one of you. I know we've talked about COPD on several days, actually. We've had elegant talks yesterday. I gave a short talk on Friday morning and this morning. And here we're talking about precision therapy. But I always remind my fellows and my colleagues that when it comes to COPD, personalized therapy also rests into choosing the right delivery system. So my first talk in the next 20 minutes, I want to build up a rationale why delivery matters. Delivery of inhaled medication, since this is the most common ways of treating COPD. And I'll focus on nebulizer. This is the topic I was given, update on long-acting nebulized bronchodilators. Although there are now drugs that are not bronchodilators that we use in a nebulized platform, which I will allude to as well. This is my ambitious sort of goals, but in a nutshell, I would like to focus on who are the patients we need to consider for nebulization? What are the advantages, pros and cons of nebulized versus other inhaled delivery systems? Unfortunately, this has not been very well studied. I will focus on some of the new inhaled delivery medications that are in a nebulized platform as well, and I will end up with some conclusion remarks. We all know this. COPD is a growing problem. I actually showed a slide this morning that in 2050, they're estimating a huge increase in the prevalence of COPD around the world. Currently, about 400 million around the world have COPD, about 24 million in the United States. But many of these patients have outcomes that are not really, not as bad, maybe as bad as the bronchiectasis that we heard about. Exacerbations tend to be a major problem, even mortality and hospitalization. Of course, ultimately, it is the 4th leading cause of death around the world. So the goals of management are nicely outlined, by all these guidelines, GOLD and others, that we want to improve things, but we also want to decrease risk factors, risk of exacerbation, ER visit, hospitalization, decline in lung function. We're still trying to figure out how can we prevent disease from progressing, and of course, ultimately, the mortality. We also know that managing COPD is not about drugs. We're going to focus about drugs today in this talk and the next talk, but it really is a multidisciplinary approach, including non-pharmacologic and pharmacologic approach, including, of course, smoking cessation, exercise, vaccination. But when it comes to pharmacologic drugs, GOLD has tried to make it simpler for us. So they suggest that we classify COPD based on symptoms, risk factor of exacerbation. And as you see here, GOLD E is the one that is highest risk. These are patients, in the past they had a C and D category. Now they only have E, those patients who have history of 2 or more exacerbation in the past year, or 1 hospital admission for exacerbation. B are very important patients. These have symptomatic COPD, but less risk of exacerbation. And A is the mildest form of COPD. So based on this, what Gold suggests that initial pharmacotherapy should rest on what group the patient has. Of course, spirometry is not in the equation. It's an important tool for diagnosis and staging, but when it comes to choosing pharmacologic therapy, it is not part of the equation. And as you see here, patients with exacerbation or group E, the first treatment approach is a long-acting bronchodilator, LABA or LAMA, or a combination of a LABA and LAMA. But in patients who have high type 2 signal with high blood eos, considering adding an inhaled steroid and triple therapy would be a good choice in that. But also Gold says this is the initial therapy. What happens after you treat them, you have to follow them up. And then when you follow them up, you approach it as in treatable traits approach. Those who continue to have dyspnea, you really need to concentrate on the bronchodilator therapy. And that's where you really have to think about, is this patient continuing to have dyspnea because he's not taking their inhaler, or is he not taking it correctly? And that's where Gold really stresses the fact that you really need to think outside the box here. Is it the delivery system? Can I change it? They also added few things, one of which is ensifentrine, which I'll talk about today at the end of the talk. It's a nebulized medication that targets PDE3, PDE4, but assessing inhaler device is very important in that group. Not to undermine this group, those with exacerbation, that's when you can escalate to triple therapy, and now we have biologic. We'll talk about that in the next talk. So coming back, the treatment recommendation has changed over the years pharmacologically. Of course, bronchodilators remain to be the treatment of choice. Now, what the guidelines don't really stress on is the choice of inhaler delivery. They do have some recommendations, which I'll share with you in a minute. Triple therapy, certainly if a patient has high eosinophil count, and of course, LABA-ICS now is taken off the map for COPD, and triple therapy is what is recommended. This is an important slide from Gold to remind us this is not a one-shot disease. It's not a one-visit disease. It's a continuous assessment, adjustment, reassessment, and part of the reassessment is the compliance adherence to therapy, but also use of inhaler device. So let me share with you one case just to build up my rationale of why personalized approach is very important when it comes to a delivery system. This is a 72-year-old white man who is a smoker, continues to smoke, has chronic cough and sputum, has COPD, diagnosed with hypertension. As you remind us that COPD does never exist in a vacuum. Most of these patients have comorbidities, which I'll share in a minute, which is important when it comes to a delivery system that you're going to prescribe to, what kind of comorbidities they have. This guy has hypertension. We don't know his cognitive function. We don't have any details from the history. He does have airway obstruction. His CAT score is 20. As you know, this depicts increased symptoms. He's now on ICS LABA, dry powder inhaler, which he's supposed to take twice a day, at least by what's documented in the chart, and he's on albuterol when needed. His past history, now we know more about his comorbidity. He has past stroke history, left him with mild cognitive dysfunction, but he still walks and he moves his limbs. We don't know about his memory. It says mild cognitive dysfunction. We don't know about his psychomotor functions, which is very important when it comes to a delivery system like a meter dose inhaler or a dry powder inhaler. His wife is accompanying him, and he's concerned that his inhaler is not working, doc. What can we do? He's still symptomatic. During the visits, I always check inhaler deliveries. I have this toy box in my office where all these placebo inhalers. Sometimes the patient brings their own inhaler. I ask them to show me how they use them. And I'm sure you probably have been surprised or shocked by some of the techniques that some of our patients have, which not as bad as House. I don't know if you've seen the House video, how she uses the MDI when he asks her. Not as bad bad, but critical errors exist. In fact, up to 92% of patients with asthma and COPD, if you test them, they have at least one critical error in using a metered dose inhaler. Now, obviously, GOLD addresses this in a very small statement, but it's still there, that the choice of inhaler device should be individualized. This is where personalized medicine starts, folks. It's not about the biologics. Sure, biologics are important, and that's for more severe patients. But when it comes to bread and butter, treating COPD, and as a matter of fact, asthma, delivery system is important. We have, and that's good to have choices. We have so many delivery systems, nebulization being, even among nebulization, we have at least 3 types. We have dry powder inhaler, we have soft mist inhaler, we have metered dose inhaler. And in fact, it can get really, really congested. You know, I mean, it's good to have all these delivery systems, but you really need to be decisive of which one to choose for your patient. Now, I have to say, not all the drugs that you want to use come in all these platforms. So sometimes you're obliged to pick a dry powder device because that's the only way I can deliver the drug I want to treat. But there are certain guidance that I will go over. It's important to keep that in mind, that we should individualize a treatment. Assessment of regular inhaler technique is important. Assessment of underlying comorbidities, including physical comorbidities, mental comorbidities. We should discuss disease preference. I always do what we call shared decision-making with the patient. Of course, cost and reimbursement can also be a decisive factor. Some of these inhalers are cheaper, and others are more expensive. So that is important as well. We have to keep that in mind. But patient's ability to perform the appropriate inhalation should always be assessed. And I told you about the 92% statistics. A few years ago, I worked with CHEST, and we published these data, actually. We surveyed not only pulmonologists, we also surveyed patients and primary care about inhaler delivery system. And what's really shocking, even when we asked pulmonologists, PCP, nurse practitioners, and that most of us as clinicians focus on the drug rather than the delivery system. So when you consider prescribed maintenance medication for a newly diagnosed COPD, which one is the most important? Is it medication or device? You can see the majority said it's the medication, not the device. And then when we asked, do you assess a newly diagnosed patient's ability to use a device, you can see that on every patient, it's less than half, and no matter which one. We also surveyed patients. You can look up I don't have time to go over the patient survey, but patients admitted that nobody checks majority of them don't have their inhaler device checked when they go to the visits. Now, it's been shown, this is a very elegant study, actually, not very well quoted by David Price and his group, and it's a real-world study where they looked at patients with COPD who have delivery system through different platform versus unified platform. And those who had a unified platform, like, you know, you chose MDI, you treat the rescue inhaler, the maintenance inhaler, and MDI, rather than giving a DPI, an MDI, a nebulizer, you know, that can actually be associated with worse outcomes. So it's interesting, and as much as we can, choosing the right device, but choosing all the inhaled delivery medication you want to give in the same platform may be the best way. Hopefully in the future we will have that luxury. There's lots of papers published. Don Moeller and I have worked together many years, and he's published a lot on this, that device attributes and patient factors will help us pick the right treatment. Ideally, only one device type should be used. That's ideal. Also, another thing is when it comes to dry powder inhaler, the peak inspiratory flow is very important. But the manual dexterity, the cognitive function, this is from Don's nice paper a few years ago, sort of giving us an algorithm how to pick the inhaler devices. But certainly, when it comes to peak inspiratory flow, I'm not sure how many of you measure it. There is an in-check device that you can get in your office, and it can tell you if a patient generates more than 60 liters per minute, then you're okay with prescribing dry powder inhaler or an MDI or soft mist inhaler. But if their peak inspiratory flow is less than 30 liters, then you're wasting your time and the patient's money, because they're not going to do well with any of the platform other than a nebulization. So there are several guidance which I won't go through this, but let's keep in mind also that 80% of patients in COPD report at least one comorbidity that may impede their delivery technique. These are listed on this slide as well. And then there are some guidance. This is a nice paper by also Don Moeller and Dave Halpin from the UK about what to do at the initial so that you can select the proper delivery system. You know, you have, can the patient perform the inhaler? Can the patient handle the device? Can the patient generate enough peak inspiratory flow? Is the molecule available in the device? And can the therapy be prescribed in the same device the patient is currently using? But not only at the initial visit, but at follow-up, you have to reassess as well. So the clinical scenarios where nebulization definitely have a real important use are listed here. Cognitive impairment, patients cannot do manual dexterity, patients who have severe pain or muscle weakness due to neuromuscular disease, patient no matter, you know, there are 9 steps using a metered dose inhaler. It's not 1 or 2, 9. And dry powder inhalers are maybe less number of steps, but you have to generate the peak inspiratory flow. So that's the list. That's a short list of a longer one. Advantage of nebulization, well, obviously accessible. 45% of patients with COPD, if you ask them, they have a nebulizer at home. They usually use it for rescue inhalers. But now we have long-acting inhalers that we can deliver through this. But also 100% of most nebulization is considered durable medical equipment and is covered by Medicare. So cost may be actually not a big issue in that population. And it's user-friendly. It doesn't really need any specific technique to use a nebulization. And in the past, they used to be bulky, and, you know, we don't ask them to carry them with them, but, you know, if they're delivering a drug once a day or even twice a day, they can keep it at home. And nowadays, there are some, like, neat nebulization that are very smart, actually, that they will only deliver a drug when the patient takes a breath. This is just some of the nebulization platforms. I'm not a fan of one versus the other. There are so many, but you need to, if you're going to prescribe a nebulizer, usually there are options, obviously, and some are more expensive than others. These are the inhaled medications available for COPD in a nebulized platform. As you see, we don't have too many of them, but still, the rescue inhalers, we know that. These are, you know, bronchodilators. The long-acting beta-agonists, we have 2 LABAs, arformoterol, formoterol. The long-acting anticholinergic glycopyrrolate is usually twice a day, and then revefenacin is a once-a-day LAMA. I'll show you some data with revefenacin. It's one of the new kids on the block. And then we have anti-inflammatory budesonide. We still use it every now and then, but the ensifentrine is the latest addition, which has an anti-inflammatory and also bronchodilatory effect. There are multiple studies, I won't have time to go through these, that looked at the efficacy but also safety of these nebulized bronchodilators. We were involved in several of these studies, glycopyrrolate in GOLDEN 3 and 4, revefenacin studies that got it approved with once-a-day LAMA, arformoterol studies several years ago, and then there have been some studies looking at acute care use, and there's a study that actually compared, and I'll show you that in chest, which was very good, because in the hospital, we use a nebulized platform. I don't know about your hospital, but our hospital, they converted to nebulization. It's cheaper, but also it requires respiratory care. So there was a very nice study. I think I have it. I'll show it to you in a second, where they actually looked at using a revefenacin versus plus arformoterol. You know, twice a day, revefenacin once a day versus albuterol and ipratropium. It was as good, actually, when it comes to efficacy. And it saves time of respiratory care. There's actually some really interesting concept that, you know, we think that they're all the same, but actually they're not. There's some data to show a superiority of a nebulization versus a regular MDI, DPI. These are some studies. This is a nice read if you're interested. Several years ago from Dr. Rajiv Dand, who's also very well known on publication on delivery systems. And this is another one where they actually looked by Sanjay Sethi from New York, where they looked at combining an nebulized LAMA, which is ribofenicin, once a day, in patients who are already on either LABA or ICS. And they showed, just like we know from DPIs, LABA addition to LAMA has a better effect on lung function. This was a short study, but it was a proof of principle that a nebulized LAMA can work very well, even if a patient is on a DPI or an MDI with ICS LABA or LABA alone. And then this is the study I was alluding to for hospital. This was published a few years ago, just a couple of last year, and very nice by Rajiv Dand, where they actually looked at it in the hospital setting, where they utilized long-acting nebulized bronchodilator, ribofenicin and R-formoterol, or formoterol in combination after 24 to 36 hours of admission, compared to the regular, albuterol, ipratropium bromide, and showed that they actually it did very well, and it reduced the time of administration. Now, it'll be nice to look at cost, because when it comes to our formulary and our hospital, you always have to show cost and, of course, length of stay. That was not looked at in this study. Finally, nebulization is here to stay. Ensifentrine was just approved by FDA last year. Was it last year? Maybe, yeah, it was last year. It's a nebulized twice-a-day PDE3, PDE4 inhibitor. PDE3 is a very good, blocking PDE3 can cause bronchodilation. Blocking PDE4 is an anti-inflammatory. But in the main trial, which was Enhance 1 and 2, it was only 6 months trial, but it showed significant effect on bronchodilation, on lung function. But it was very nice to see that even though it was not the primary endpoint, there was a reduction in exacerbation. Now, this drug is approved now by FDA. You have to fill up special forms to get it. And usually Medicare is good in reimbursement because it's a nebulized drug. So lastly, treatment of COPD starts with picking the right treatment, the right device for the right patient. But also, all these things have to be implemented. Inhaler device is important, asking and shared decision-making with the patient, reassessing the patient every time they come in about how they feel, how their delivery system is, are they using their inhaler, any problems. It's very important to ensure adherence to treatment. So inhaled therapy continued to be the first and the best way to delivering drugs to the lung in COPD. The choice of inhaled delivery is very crucial for a personalized approach to COPD. Consider patient's history and comorbidities. Consider patient's physical and mental ability. The older the patient, unfortunately, this has been shown, the older the patient, the lower the peak inspiratory flow rate. If you have the ability to to have an in-check device at your office, you can do that. If you're not sure if the patient is going to do well with DPI, a different platform maybe. And then lastly, working with a multidisciplinary team is very, very important. Thank you. This ends my first talk.
What I'm going to do is give Nick 30 seconds of breath. That was fascinating. Great coverage. But I'd like to push on with your next talk.
Yeah.
Save your questions till the end, and then we'll bundle the bronchodilator aspects with the type 2 inflammation. So,
Sure.
Nick, back to you.
Yes, so now I was also asked to address the other end of the spectrum, the more severe patients. Nowadays, in the era of precision medicine, you heard a very elegant talk by Dr. Chelly yesterday on biologic. I'm going to share with you where we are with this field, and particularly when it comes to type 2 inflammation, which is one of 3 endotypes we know that COPD has type 1, type 3, which is the more common, usually characterized by neutrophilic inflammation, and then type 2 affects 30 to 40% of patients. So I'm going to talk about updates in this area. What do we know about type 2 COPD? Why is it important? How do we identify patients with type 2 COPD, particularly high-risk patients? And then talk about the approved biologics for this type of COPD and where we're going next in this field. So you've heard me talk about COPD and its impact, and this vicious cycle, unfortunately, continues to haunt us as clinicians, but haunt more our patients and, of course, our healthcare system. A significant number of patients with COPD diagnosed, at least another 15 million probably have COPD in the US, but don't have the diagnosis. Significant ER visits. In the US, it's the 6th leading cause of death. It's the 4th leading cause of death in the world. And not only that, but these exacerbations that occur in with this disease are associated with increased airway inflammation, more hospital admission and readmission, poor quality of life, and high mortality. We know this because we've looked at statistics, both from cohort studies, epidemiologic studies that have been published, clinical trials. We continue to see that every aspect of the patient's life is affected, especially if they have repeated exacerbations, including the ability to live long. We know that hospitalized patients with COPD, it's been shown that 50% of them will die within 4 years. This is a shocking statistics. And not only that, but severe exacerbation requiring hospital admission is increased it increases risk of subsequent admission and of course mortality. So goals of management of COPD certainly, as you see here, has been to minimize the negative effect of exacerbation. That's one of the major goals. Now, we also know that over the years, we know that there are at least 2 endotypes of COPD that have been identified. Type 1 and type 3 are lumped together because even though there may be different triggers, different cells involved, they are associated with neutrophilic endotype. And these are hard to treat because we don't have good targets. Now, DPP1 may work. They asked me this morning, will it work in COPD? I don't know, but the neutrophilic inflammation is common in these patients. And a third of COPD patients, as you know, have bronchiectasis. So we don't know. I think we need to still stay cognitive about all these new development from other airway diseases. We learned a lot from the asthma word about type 2 inflammation, but it does exist in COPD. About 40% of patients with COPD, even if they don't have a history of asthma, they have some signs of type 2 inflammation, usually reflected on by peripheral blood eosinophils or airway eosinophils being high. And this group of patients with type 2 inflammation have been shown to have higher risk of exacerbation and higher risk of decline in lung function and highest risk of readmission to the hospital. This is one of the 2 confusograms that I'll show you, but it really shows you the type 2 inflammation, the pathway. It starts with the epithelial cytokines, which, by the way, are being looked at for targets now. We talked about one of them this morning, but TSLP, we know in asthma, we have a treatment which has been looked at in COPD. But downstream, there is both an adaptive immune system and an innate immune system play a role in type 2 inflammation in COPD. And the propagators are these type 2 cytokines. Interleukin-5, very important for eosinophil to mature, to be recruited, and it may have a role in remodeling. IL-4, IL-13 are very important cytokines for different reasons, one of which is eosinophilic recruitment, but IL-4 plays a role in B-cell isoswitch and IgE production. IL-13 has a very important role in eosinophilic recruitment, but also in airway remodeling, mucus hypersecretion. And obviously, these cytokines have been looked at in depth from the asthma field, but now we're learning more about it in COPD. IL-5, as I mentioned, has several, other than eosinophil, has several other important effects on epithelial barrier dysfunction and fibrosis, mucus plugging, dysregulated immune response, and airway remodeling. We talked about IL-4 being a very important one in iso-switch of B-cell and IgE production. IL-13 has pleiotropic effect as well. So the bottom line, type 2 inflammation is important. Not only that it predicts poor outcomes, but it also really is one of the main culprits why these patients have airway obstruction, mucus plugging, airway remodeling, and let's not forget alveolar destruction. There's some good data, at least, to suggest that type 2 inflammation patients have a higher risk of alveolar destruction, what we see in emphysema. GOLD now has addressed this in the last 2 years now. They've talked about blood eosinophil, which depicts type 2 inflammation, that it's associated with a predictive effect of response to inhaled corticosteroid, increased risk of exacerbation, rate of lung function decline, and even in cohort studies, greater risk of future COPD development, which is very interesting. But there is also the very good correlation with elevated lung eosinophils. So blood eosinophils, although can be elevated because of other things, and that's very important for us as clinicians. Somebody who comes in with COPD, very high eosinophil, you want to make sure it's not other things causing it. Like I see lots of immigrant population in my practice, I always check for strongy antibodies. I always look at drug allergies or other reasons before you just say, oh, this is COPD with type 2 inflammation. And some of these patients may have ABPA and concomitant asthma. 15 to 20% have asthma COPD overlap, which is fine, but I think you really need to keep that in mind. Also, when you look at high eosinophils, you don't look at it one measurement. And I think looking at it over the 1 year, we use EPIC in our institution, so I look at the 1 year measurements and see. And there's been studies now showing the fluctuation from day to day in the same patient. So a one-time measurement is not enough. You need to look at it, and historic eosinophils are very important as well. So coming back to how is that going to change my treatment? And GOLD has really sort of revolutionized based on evidence that the treatment of COPD shouldn't be a one-size-fits-all like we do all the time. It should be personalized. We talked about personalizing based on inhaler delivery system. But when it comes to more severe patients, you want to look at the phenotype and the endotype. We've been talking about endotype, and phenotypes are important. But phenotypes is like the iceberg. When you look at it outside the water, that's the phenotype, the clinical presentation. Chronic bronchitis is a phenotype, a very important one. These patients have a higher risk of exacerbation. Frequent exacerbation is a phenotype, important one. Rapid lung function decliner is another phenotype. There is also radiologic phenotypes, airway predominant or emphysema predominant phenotype. These are important, but when it comes to endotype phenotypes, we use biomarkers. Right now, there are not too many out there. Blood eos is the main one we use. We're toying around with FeNO in type 2 inflammation COPD. There is some emerging data that may be helpful. But we have to be careful with FeNO. It can be lowered with smoke exposure and smoking. And there may be others that are, and then of course, treatable trait approach. So basically an exacerbator or a dyspnea patient, which one to, how do you treat? So let me show you a case for this so that I can build up the rationale for advancing treatment. This is a patient with emphysema with stage 4 COPD, 40 pack here, smoking, has diabetes and hypercholesterolemia, just to remind us that many of these patients have other comorbidities. When I saw her, she was only on a LABA and LAMA, which is appropriate initial therapy for these patients, bronchodilators. I'm not saying here if it's DPI, MDI, because I frankly don't remember this woman, whether she was on a nebulization or, but that is important though, now that she's coming to me because she's had 2 exacerbations and had hospitalization the past year. So she's definitely a gold group E here, no matter what her FEV1 is, but her FEV1 is pretty bad, 28%. Spirometry post-bronchodilator. We looked at her CBC. Historically, her eosinophil was repeatedly more than 300 cells. Denies history of asthma and has had exacerbation. Just to remind you what I showed you in a different presentation, that the initial therapy for this type of patient, LABA-LAMA is appropriate, but reminder, with her high EOs and exacerbation, that's the type of patient that you would escalate to a triple therapy, definitely, at the least, at the initial encounter, and check an inhaler device, and also go over the exercise and pulmonary rehab issues, and also smoking cessation and vaccination, very important. So obviously, this patient, what we did is we did escalate to triple therapy. We recommended pulmonary rehab. We asked her to avoid secondhand smoke. We made sure she's up to date with her vaccination. And we started talking about, well, if she continues to exacerbate, this is a type of patient that you may need a biologic. I don't rush into prescribing biologics. even in asthma, I take my time, I make sure I educate the patients. The patients need to know what they're stepping into. This is a long-term treatment, I hope you all agree. And a shared decision-making should start from visit one. So usually these type of patients, I give them things to read, a website if they have a computer. I start talking to them. Maybe we may need to start injections. And obviously, many of these patients will have lots of questions. Oh, goodness, am I going to inject myself? What about my inhalers? How much is it going to cost me? All these questions you have to be prepared to answer. And if you have a person in the office, nurse practitioner, or somebody helping you, they can do a good job, but you really need to address their concerns. Otherwise, you're going to lose even though you're going to go into a biologic, you need their adherence to your therapy. Just to remind ourselves, this is a continuous circle of adjusting and assessing, including assessing inhaler delivery system as well, and triggers. So this patient comes back, and we know she has emphysema and gold stage. So in addition, I usually do lung cancer screening, CT, if she hasn't had it. But in this patient, she did. So back to her. So she has now another blood. I check blood EOs on every patient who comes to me referred for COPD. That's been my trend right now. I don't check FeNO on everyone yet, but in asthma, I do. So her recent EOs are 375. She feels better. She had less risk. This is 6 months after. But she has slightly improved mobility, but she's still dyspneic. She's still symptomatic. Now she has also occasional chest pain, and that really scares me usually, because cardiovascular disease is very common concomitant comorbidity, and she has elevated CRP. So in her case, obviously we are justified to keep going with triple therapy, but here, despite that, she's still exacerbating, and that's where type 2 COPD and whether she's a good choice for biologic comes in mind. Right now, Gold has, in the last iteration last year, added dupilumab, which is approved last year, and obviously we're hoping that they will also add mepolizumab. Now, there are 2 biologics approved for COPD, for type 2 inflammation, like this woman. So again, back to her, initiated type 2 biologic. We'll talk about the 2 that we have, but shared decision-making. And also, I ordered an echo, and usually I refer to cardiology because I would like them to make sure her heart is okay because of the chest pain. Just to remind ourselves that despite that triple therapy is very important, it revolutionized our treatment approach for COPD. But we have to keep in mind that 50% of patients on triple therapy continue to exacerbate. This pie graph comes from the IMPACT trial. This was a large trial we were involved in, looking at triple therapy over the year in high-risk COPD patients like this woman. And even though 53% did not have exacerbation during the study, the 47% did. And then actually there is other studies that showed same. And in the real world, about a third of patients on triple therapy continue to exacerbate. So yeah, we have improved our outcomes with inhalers and triple therapy, but we're not there yet. We didn't put a switch off to exacerbation. So coming back to that, this is a slide that you saw from Dr. Chelly yesterday from a nice paper in the Blue Journal. We have several targets, but I'm going to share with you only the data we have on the approved targets, the anti-IL-5 mepolizumab and anti-IL-4 receptor dupilumab. So both are approved now, and the approval, the trials that got these approved were listed here, the Boreas and Notice and the Matrix Metrio and the Matinee. And the patient population is in a way similar but somewhat different. And we were one of the sites, and I'm one of the authors on these studies. In Boreas and Notice, we enrolled patients with triple therapy who had exacerbation 2 or more and had to have high EOs more than 300 and had to have chronic bronchitis. We did enroll symptomatic patients, MRC dyspnea 2 or more, but we did not enroll Gold 4 COPD like this woman. We tried to avoid enrolling very severe COPD. It's a 1-year study, placebo-controlled, even though on top of triple therapy. And I'll show you the data in a minute. And we got the dose that we tested is only one dose, not like in asthma where we have 200 and 300. With the matinee study, we were also involved in this one. We enrolled patients with high risk of exacerbation, but we enrolled patients with stage 4 COPD, GOLD 4, but we didn't necessarily request that they have to have MRC dyspnea more than 2 like we did. So there are some differences in a way. It was all added to triple therapy. But in matinee, we requested that they had to have 300 or more on enrollment and 150 cells eosinophil in the past year. That was based on the previous METRIX and METRIO study. So the METRIX study was an older study. It was actually the very first study that addressed eosinophilic COPD, if I may use that term. Some people don't like eosinophilic COPD. COPD with type 2 inflammation is a better, more wordy talk. But in Pavor and his group here, they looked at, METRIX and METRIO. And one of the study where they looked at patients enriched with high EOS, mepolizumab was able to reduce exacerbation. But in the other study where they looked at the whole population, it didn't. So FDA at that time did not approve it for COPD with high eosinophil. But when you look at meta-analysis looking at different cutoff of eosinophils, there is clearly a trend where the higher blood eosinophil at baseline, the higher or the better effect in exacerbation. So that led to the matinee study, which was published earlier this year and got this drug approved now by FDA. I told you about the patient population that we enrolled with matinee. And it was interesting because it was done during COVID, but we also followed these patients up to 2 years, not 1 year. Half of these patients were followed up to 104 weeks. And it was mepolizumab, the 100 milligram every 4 weeks, plus standard of care, or placebo. And this was the primary endpoint, time to first moderate severe exacerbation. We also looked at patient-reported outcomes and exacerbation requiring ED visits or hospitalization. And of course, lung function was also one of the outcomes that we looked at. So the main outcome was positive. There was a 21% reduction in annualized rate of moderate severe exacerbation over at week 104 compared to placebo. The cumulative number of moderate severe exacerbation is seen here. You can see the separation was pretty quick actually early, but it was sustained over the 2 year of the study. However, the patient-reported outcomes were not affected with this treatment, neither was the lung function. But what we found is also there was a 23% significant reduction in the time to first exacerbation, which was significant. And this was this was a secondary endpoint where even though the numbers are very small of hospitalized patients or patients requiring ED visits, if you do the math, there was a 35% reduction. But again, no effect on PROs or lung function in this study. And the safety was very promising. We were always worried because these are older population. In general, there's really no signal compared to placebo, neither in the matinee or METRIX or METRIO. The study that got dupilumab approved, the studies are Boreas and Notice. They had a very similar design, very similar patient population between both of them. Again, patient population always had to be on triple therapy, had to have high EOS, 300 or more, had to have chronic bronchitis. That was one of the differences between matinee and here. Matinee did not require chronic bronchitis. This one, we did require chronic bronchitis, although some of our patients had self-reported emphysema, but we didn't do CT scans in either one of the studies. The bottom line, the primary endpoint was also annual rate of moderate severe exacerbation after 1 year. And of course, we had several lung function and PROs were secondary endpoints. You've seen these data yesterday. Dr. Chelly showed you when you combine both, we had 30% reduction with Boreas, 34% reduction with Notice. And when you combine both, there was a 31% reduction in moderate severe exacerbation and improvement in lung function. This is pre-dose FEV1. But we also saw a good statistical improvement in patient-reported outcome. SGRQ, as you know, this is the quality of life over time. The lower the SGRQ, the better quality of life. We also looked at ERS-COPD, which really, it's a questionnaire depicting symptoms, a cough, shortness of breath. Also, there was a significant improvement. And safety was also pretty reassuring in both of these studies. So now we have two biologics. Obviously, it's always, you scratch your head, which one should I choose? I think it comes back to also patient decision-making. Both have shown efficacy in subgroup of patients with high-risk exacerbation, with high blood eosinophils, and also with the cutoffs. The approval for Dupi is 300. For the mepolizumab, they got, based on FDA discussion, based on the metrics, there's really no hard cutoff in the indication by FDA, but there is a potential use for patients at lower than 300 cells, 150 and above, based on the metric study. There are lots of others. I won't have time to go through all these designs. We're involved in several of these studies ongoing to look at. Some of them target type 2 inflammation. Others may target both because they target the alarmins or epithelial cytokines. The anti-IL-33, the anti-TSLP, benralizumab is another drug that Resolute study is ongoing. We will see the results at the end of this year, hopefully. We may have another biologic approved for eosinophilic or COPD. I have to end with two slides because when I was asked what are some challenges, I presented this at ATS as well. Some challenges. Obviously, it's not a smooth road out there. We're not claiming that a majority of patients with severe COPD will end up on biologic. It's estimated based on our assumption that 1 to 8% of patients may meet eligibility right now. Subgrouping and determining who will respond best is now targeted towards biomarkers, especially blood eosinophils right now. I think there's a need to look at whether these biologics would work if a patient is on dual therapy and not triple therapy. We don't have those data. Do they work in smokers the same like ex-smokers? Yes, from these trials it did. Because I get a question, are we justify prescribing a biologic for somebody who continues to smoke? And I pose a little, I said, is it me to decide? If clinical trials show that they do work, why am I going to depriving this patient if they continue? Of course, I have to advise them to stop, but is it ethical to deprive them from a drug that may work? I think that's an ethical question. I don't think I do, but some of my colleagues asked me and questioned whether I really should do it because they continue to smoke. So there are key criteria. Right now, we use a blood eosinophil and frequent exacerbation and airflow obstruction. Of course, we need to know what the payers will use. Payers may include Medicare here because many of these patients are in the Medicare age group. And so government now has been, so far, we've had successes in getting it reimbursed. But again, it's important to keep that in mind. And there are important considerations. What is the effect of these biologics on comorbidities, particularly cardiovascular comorbidity? We don't know. In these 1 year, 2 year study, there was no increased risk of cardiovascular. But I like to see, is there a benefit on cardiovascular comorbidities? We don't know. We know that exacerbation can trigger patients to have myocardial infarction and cardiovascular complication. Should we be looking at these outcomes? My last slide, the future direction is for us as clinicians, as clinical researchers, I think there are lots of things that we need to answer. And there are studies ongoing, by the way, to look at the effect on disease modification. Just like you heard very nicely from bronchiectasis, can we actually prevent the decline in lung function in these patients? What happened with mucus plugging? We can now quantify mucus plug scores on CT scans. We have a biomarker that we can follow. What happens to emphysema? Can we reverse it, or can we improve architecture of the lung? What about small airway function? Can we use these biologics for people with lower eosinophil count, less than 300? What's the role of other biomarkers like FeNO or composite biomarker? What about non-smoker COPD? These have never been studied. All these trials were on smokers and ex-smokers. And of course, there are studies now. We're starting studies about reducing readmission. There's some really elegant studies coming out from the UK on using biologics in the hospital setting if they have high eosinophils. One such study called ABRA was published recently by Mona Bofadel in Lancet. So, and of course, I think long-term safety is always important. More than 2 years, what happens on a long-term basis. So this is my summary slide. I won't go through it for sake of time. You can read it. But basically, I think there is really excitement in the air when it comes to COPD. But it comes back to personalized approach, and it's not just a one-size-fits-all disease. And it's not about blue bloater and pink puffer like we used to know in the past. There's much more to the story than that. Thank you so much for listening.
Fabulous job, Nick. Could I have slide 10 or 27? Happy to take a question or two. The reason I want to bring this up is we heard elegantly about what's coming down the road with regard to alarmins. The alarmins are which ones? That's TSLP, IL-25, and IL-33. But
is it 10 in
I want
my
the
last
cartoon.
presentation?
Yeah,
My last presentation?
No, the the last presentation, sorry.
Okay.
The cartoon that shows type 2 inflammation. So keep going. Whoop.
This is the nebulized one.
This is all nebulized. Yeah, it's the second presentation.
Yeah, sorry.
Well, in any case, we're seeing very linear drawings that the alarmins lead to IL-13 and IL-4 or IL-5. And that implies, as the anti-alarmins, yes, that implies that everything's going to go through an alarmin to IL-4, IL-13, and IL-5. What we know in asthma is there are people who are responders to anti-IL-4 alpha drugs, and the anti-alarmins didn't work. Mm-hmm. And the reason, if you have the...
Yes, there's a point.
The reason to keep in mind is although all my colleagues draw this very linearly, and if I went upstream, I take out everything, is not the case. Mm-hmm. What we know is there are ways to activate 4 and 13 and 5 pathways that do not require the alarm.
Good point.
So, when you prescribe a biologic and you say, oh, I'm going to go upstream and take out everything, and you get a non-response, that means that alarmin is not driving a potential 13 and 4 signal or 5 signal. So we, as experts, should not be drawing this as singularly serial, but have arrows that show that 13, 4, and 5 pathways can be activated
directly,
independent of the alarmins. Because you as a provider have to figure out why an anti-IL-4 alpha receptor antagonist work when I started with an anti-TSLP, and shouldn't that have worked also? Mm-hmm. Answer, some of these pathways are independent of the alarmins. We hope they are going to be alarmin dependent. Truth be told, there's heterogeneity.
Good point. Thank you. You needed to show another slide? Or?
No, that was it.
Okay.
So what I want to do is close this meeting, giving ample time if you have a question for Nick to come up. I want to thank you all for being the iron people, hanging out into another CME. I want to thank Academic CME and applause. This was fabulous. Please scan the QR code. This is how you're going to get your CME credits. And again, hopefully you did the pre-test. With that, I'd like to close. I know Nick can
I'll stick around, or yeah.
Yeah, and you could, if you want to ask Nick or use the microphone. Some of us have to catch a flight before the thunderstorms.
Why don't I stick around here?
Yeah, just stick around here.
Yeah.
Thank you all so much.
Thank you.
any questions? There we go. Let me bring the microphone. Oh, yeah. Sorry, you okay?
No, I'm good.
Yes, sir.
Thanks for that talk. That was really good. I want to know, like, obviously the eosinophil count's critical. When do you measure eosinophil counts in these patients? You know, they're on steroids all the time.
Yeah.
It's often hard to get a real eosinophil count. The other question I have for you is, do you have any concern about the home administration of like Dupixent? I've found that a lot of patients don't follow up as well
Yeah.
when they get it at home, and there's a big push for that, I know. But those are my two questions.
Thank you for the questions. No, it's a very legitimate questions. For the blood eosinophils, definitely not while they are on oral steroids because it's useless, not during the hospitalization. Now, you can look at initial CBC in the ER before they are given steroids. I usually go back in the history because when they are in the primary care setting, because we do have in our system, I have access to the community clinic, which is part of the system, so I can look at their EOs over time. If you want to wait, if you're at least 2 weeks after they come off systemic steroids, to be accurate, to be honest. Right now, we don't have any point-of-care tests for eosinophils other than blood eosinophils. There are people are working on looking at upper airway EOs and like point-of-care tests, like a litmus paper to tell you, to measure eosinophil protein. We don't have that yet. And then the second question was injections at home. Absolutely. I mean, it's the same like we talked about the inhaler. I mean, usually these are auto-injectors. Many of my patients are already on injections like for insulin or for GLP-1 or other things, so they don't have a problem. That's why it's important to also address the caregiver if it's an older patient, because many of these patients are older. They may have dexterity problems. Talking to the caregiver, maybe, and we also have all these demonstrator pens in our clinic to show them. Some of my patients, despite that, they want to come in to get the injection, which is fine, but it's, you know, if it's every 2 weeks, sometimes it's cumbersome to do so. And then some of these patients, like I know from my asthma world, because I do carry both hats, we connect them with infusion our infusion center in the hospital. But again, in fact, some of them get that it gets cheaper for them if they go through our infusion center, and that's more in the asthma. I haven't had that in COPD yet. Okay.
Okay, well, thank you very much.
Thank you so much for sticking around. Have a great trip back home if you're traveling. Thanks.